Standard treatment workflow for bacterial skin infections. First one is impetigo. The clinical features are wet yellow brown crust overlying red inflamed skin. Types of impetigo. The commonest is non-bullous impetigo. Then there is bullous impetigo. Affected age group usually involves children. The common site of presentation involves the face, that is the perinasal or perioral, and the extremities. In extensive cases, can present with scabies or atopic eczema. Management of impetigo: topical antibiotics for 5 days, oral antibiotics for extensive involvement or numerous lesions, lymphadenopathy, or outbreaks to prevent transmission. Second topic, ecthyma. Clinical feature involves black, thick crust or eschar with underlying ulcer and surrounding redness and edema. Management includes treatment with oral antibiotics for 7 days. Gentle crust removal may be attempted after soakage with sterile saline and topical antibiotics over the exposed ulcer. Topic 3, folliculitis. The clinical feature presents as hair follicle centered pustule or papule. We have to rule out non bacterial causes like oils, chemicals, waxing, epilation, and occlusive dressing. For recurrent folliculitis, it is a recurrent infection or outbreak in multiple members of family which may indicate nasal Staphylococcus aureus carriage or human pet transmission. Management of folliculitis includes topical antibiotics for 5 days and oral antibiotics for multiple lesions. An anti-inflammatory like paracetamol 500 mg or ibuprofen 400 mg SOS can be given for pain relief. Furuncle. Clinical feature includes painful follicle-centric nodule or pus point or impending bulla or ulcer with marked surrounding erythema, edema, and induration. Management includes for small lesions, oral antibiotics with topical antibiotics to reduce contamination of surrounding skin, and for large lesions, incision and drainage or debridement, and ancillary antibiotics if systemic inflammatory signs, associated septic phlebitis, multiple or large abscesses, prominent cellulitis, and immunocompromised state is present. Hospitalization and IV treatment will be required for severely ill patients with injection ceftriaxone 2 mg BD or injection amoxicillin clavulinate 1.2 grams TDS, alternatively injection clindamycin 600 to 900 mg TDS. Carbuncle. Clinical feature presents as a confluence of multiple closely spaced furuncles, pus draining from multiple follicular orifices. Commonly presents over the nape of the neck, on the breast, and buttocks in uncontrolled diabetes. Management includes for small lesions, oral antibiotics with topical antibiotics to reduce contamination of surrounding skin, and for large lesions, incision and drainage or debridement, and ancillary antibiotic if systemic inflammatory signs, associated septic phlebitis, multiple or large abscesses, prominent cellulitis, and immunocompromised state presents. Hospitalization is required for severely ill treatment, and IV antibiotics such as injection ceftriaxone 2 gram BD or injection amoxicillin clavulinate 1.2 gram TDS, and alternatively injection clindamycin 600 to 900 mg TDS. Cutaneous abscess. Cutaneous abscess present as a pain, warm, red, fluctuant skin swelling. Management for small abscesses include oral antibiotics with topical antibiotics to reduce contamination of surrounding skin, and for large lesions, incision and drainage or debridement with ancillary antibiotics if systemic inflammatory signs, associated septic phlebitis, multiple or large abscesses, prominent cellulitis, or immunocompromised state is present. Hospitalization and IV treatment required for severely ill patients with injection ceftriaxone 2 gram or injection amoxicillin clavulinate 1.2 gram TDS, alternatively injection clindamycin 600 to 900 mg TDS. Cellulitis. Clinical features include an acute spreading infection of skin involving subcutaneous tissue. Presents as painful, red, tender, diffuse swelling, mostly involving the limbs. Erysipelas present as a more superficial, bright red edematous painful area with a clear demarcated edge and presence on common sites such as lower extremities and face. It is often associated with lymphangitis and lymphadenopathy, and broken skin or portal of entry may be visualized. Management is according to disease severity. For mild cases, that is typical cellulitis or erysipelas with no focus of purulence, management involves outpatient treatment with oral antibiotics, elevation of affected area to allow for dependent drainage, and treatment of predisposing factors. Anti-inflammatories such as ibuprofen 400 mg twice daily or indomethacin 75 mg twice daily may be given. For moderate cases, that is typical cellulitis or erysipelas with systemic signs of infection, management involves hospitalization and parenteral antibiotics, including injection ceftriaxone 2 gram BD or injection amoxicillin clavulanate 1.2 grams TDS. Alternative to the allergic to penicillin is injection clindamycin 600 to 900 milligram IV TDS. For severe cases with poor response to oral antibiotics, immunocompromised, those with signs of deeper infection like bullae, skin sloughing, or systemic signs of infection like hypotension or weak organ dysfunction, management involves empiric broad spectrum IV antibiotic coverage, vancomycin with piperacillin tazobactam, then surgical debridement, and sensitivity profile based modification of antibiotics. Investigations involve swabs for gram staining and pus culture. Blood cultures and biopsies are not routinely recommended but are useful with comorbid conditions like malignancy on chemotherapy, immunocompromised states, animal bites, etc. Complications include subcutaneous abscesses, blistering, which is often hemorrhagic, ulceration, tissue necrosis, myositis, and septicemia. Staphylococcal scalded skin syndrome. Superficial peeling of skin due to toxin producing strains of Staphylococcus is involved in Staphylococcus scalded skin syndrome. It starts as a tender and warm erythema and progresses to localized or generalized exfoliation with fever, malaise, with or without dehydration, and electrolyte disturbances. It follows a local staphylococcal infection of either skin, throat, nose, umbilicus, or gut. Bacteria cannot be demonstrated from blisters, but the cultures from original site may be positive. Treatment is preferably inpatient. For mild cases, we give oral anti-staphylococcal antibiotics. For severe cases, IV antibiotics can be given. We should consider methicillin-resistant Staphylococcus aureus, that is MRSA coverage also. The symptoms usually remiss within a week in children and it causes high mortality in adults. Red flag signs to look out for are temperature more than 100.4 degree Fahrenheit, WBC count more than 12,000 or less than 4,000 microliter per microliter, heart rate more than 90 beats per minute, or respiratory rate more than 24 per minute, and these may indicate sepsis. Severe pain following by deceptive absence may indicate necrotizing fasciitis. We should also look for dark discoloration of overlying skin. General principles of management is skin hygiene, advice on hand washing or local hygiene, avoidance of oil application, and adequate nutrition. For recurrent or severe lesions, evaluate for nasal carriage, diabetes, underlying skin conditions like scabies or atopic dermatitis. In immunocompromised patients or diabetics, consider the need for gram-negative coverage. Pharmacotherapy, that is antibiotics for skin and soft tissue infections, prefer beta-lactams like amoxicillin 500 mg TDS, 25 to 50 mg per kilogram per day, cloxacillin 500 mg QID, 50 mg per kilogram per day, cephalexin 250 to 500 mg QID, that is 25 to 50 mg per kilogram per day, amoxicillin clavulanate combination 625 mg TDS. If allergic to penicillin, erythromycin 500 mg QID, that is 40 mg per kilogram per day, and clindamycin 300 to 600 mg BD or TID 20 mg per kilogram per day. For nasal carriers, 2% mupirocin ointment for 5 days a month can be given, and topical antibiotics like mupirocin cream 2%, fusidic acid cream 2%, or framacytin cream 1% can be advised. In all patients, suspect the need for MRSA coverage if they have poor immune status, severe systemic signs, MRSA infection elsewhere, or if there is no improvement in 48 to 72 hours, and if there is penetrating trauma. The oral antibiotics for suspected or confirmed MRSA infection involves cotrimoxazole DS 2 tablets BD, doxycycline 100 mg BD, or minocycline 200 mg BD or linezolid 600 mg BD. IV antibiotics for MRSA infection involves vancomycin 15 mg per kilogram BD, linezolid 600 mg BD, clindamycin 600 to 900 mg TDS. Antibiotic susceptibility patterns may vary with region and time.